This lecture is the second in a four-part series about pediatric EEGs. It will be conducted in a question and answer format. A key point in declaring an EEG normal is to establish the absence of abnormal grapho elements. And for this purpose, not mistaking a normal grapho element for an abnormal one is paramount. This talk will address specifically this issue. So the first question is, not mistaking normal grapho elements for abnormal ones requires an organized approach. A true, B false. When you see a grapho element, you must ask yourself if it is normal, often refers to as a normal variant, or if it is abnormal. It is good, before starting to analyze a waveform, to formulate a Gestalt differential diagnosis. That is, based on the initial observation of the grapho element, to give it a tentative name or label, and to create a list of other possible grapho elements. After constructing this list, then you will be ready to start a step-by-step approach to waveform analysis. The first step in identifying a grapho element is to determine the state during which the grapho element occurs. The second step is to look for artifacts known to be linked with the specific benign variant. The third step is to make sure that we're using the right montage to look at the specific grapho element. The right montage is the one that allows us to see the features that define a grapho element more distinctively. Choosing the right montage is very important. It is very important because it influences all the following steps, which are waveform description. This is done by noticing the shape, amplitude, and duration of the waveform. The frequency, the distribution, and the reactivity of the grapho element. The last and most important step in analyzing a grapho element is to select among all those features those that are most distinctive and that allow the separation of that grapho element from other benign or pathological grapho elements. So the answer to this question is true. Next question. After careful deliberation, all neurologists involved in the evaluation of an EEG agree on how a grapho element should be labeled. A true, B false. The answer to the prior question is obvious for all of those that have been trained in neurophysiology. But having said this, it is important to stress that in most instances a general agreement can be reached among most neurophysiologists of how to label a grapho element. As I said, that is among most neurophysiologists, but certainly not about all neurophysiologists. So the answer to this question is false. Next question. A waveform lasting more than 0.5 seconds and having at least 4 phases is called a dash. A. Discharge. B. Complex. C. Burst. D. Spike. First and foremost, it must be reiterated that the description of a wave is totally dependent on the montage being used. Having said that, it is also important to stress that the terminology used is common to all waveforms regardless of the montage that is being used. So we can label waves as monophasic, biphasic, triphasic, and polyphasics. Labeling this way in this term depends on the time they cross the baseline. A biphasic wave crosses the baseline once. A triphasic wave crosses the baseline twice. Waves can also be described as monomorphic if all the waves constituting a rhythm or a burst look the same, or polymorphic if the waves within a rhythm or a burst do not look the same. Wave, because of their shape, can be classified as arc-like, notch, or sawtooth-like waves. According to the duration, they may be classified as spikes, or as sharp waves. They may also be classified as slow waves. These three waveforms may be considered discharged because they have no more than 3 phases. The term discharge is also used for a waveform lasting 0.5 seconds or less, regardless of the number of phases. Waveforms can also be described as complex when they are constituted by different looking elements. Burst when they last more than 0.5 seconds and have at least 4 phases. Spike and wave. Polyspikes and wave. And they can also be classified as runs or trains when similar shaped waves follow each other in tandem. Waveforms can also be classified as harmonic when their frequency is in an integral of a functional frequency. Usually the term subharmonic implies a frequency to be 1.5 of the fundamental frequency, and superharmonic when it is twice the fundamental frequency. This term is usually used for alpha activity. Waveform can also be classified according to their structure within a rhythm as irregular or regular. Regular waves can be identified as sinusoidal, wicket, or spindle, like according to their formation. So the answer to this question is C. Next question. Alternating asymmetry of more than 50% is usually a pathological finding. A true, B false. The description of a waveform includes its absolute amplitude, which has to be measured according to the specific derivation being used, and the relative amplitude, which is judged by side-to-side comparison. In general, an asymmetry from side to side of less than 50% is considered not pathological, and therefore it is talked about it as being symmetrical. This reason for this contradiction is that when an asymmetry is only 50% or less, the likelihood of demonstrating an anatomical pathology is very low. In this frame, I have represented an asymmetry of less than 50% as the presence of no asymmetry at all, and made it as two lines separated by the same distance between them. Asymmetry of more than 50% can be normal or abnormal. When alternating, they tend to be normal. I will represent alternating asymmetry of more than 50%, as you can see in this frame. When an asymmetry is constant, the asymmetry will be abnormal in most of the cases. Constant asymmetry will be represented by two sets of lines separated by a different distance between them, as you can see in this frame. So the answer to this question is false. Asynchronous unilateral discharges are often present in EEGs. A true, B false. To determine the distribution of a waveform, we must consider its location. Location will be provided based on electrode position. We must also consider synchrony. Synchrony will be represented with clocks with the same time and an unbroken line between hemispheres. Asynchrony will be represented by clocks with different times and a broken line between hemispheres. Unilaterality will be indicated by a line on one side pointing to one hemisphere. So the answer to this question is false. In order for a wave to be asynchronous, it has to be bilateral. Next question. The most common artifacts that aid in the diagnosis of benign variants are A. Fast eye movements, B. Slow eye movements, C. Body movements, D. All of the above. The most common artifacts that guide in the recognition or identification of graphoelements are fast extraocular movements, slow extraocular movements, chin atonia, and body movements. So the answer to this question is D. Next question. Please look at this frame and analyze the epoch presented. Choose from the options below. A. Lambda. B. Mu rhythm. C. Wicked rhythm. D. 14 and 6 Hertz positive burst. The answer is D. Next question. Which of the following is true regarding 14 and 6 Hz positive burst? A. Maximal during infancy. B. Usually lasts longer than 3 seconds. C. Preferred montage is common referential to contralateral ear. D. The field has a positivity at the nasopharyngeal electrode. 14 and 6 Hz positive burst have also been called 14 and 6 Hz positive spikes and stenoids. In this epoch, I have highlighted and enlarged the graphoelement so you can see its configuration better and appreciate the similarity between the two structures presented in this frame. The picture you saw in the prior frame was from the scale of a fish, which you can see in this frame are called stenoids scales. 14 and 6 Hz positive burst are usually first seen at around 3 years of age. They are maximal between 12 and 15 years of age and are rare in adults. They have been reported to be present in 2% in some series and in 58% on other series. 14 and 6 Hz positive burst must be distinguished from wicked rhythm, mu rhythm, rhythmic mid-temporal theta discharges, and epileptiform discharges. They tend to occur during drowsiness and early sleep. As such, when they occur with drowsiness, they are often seen in the presence of slow eye movements. 14 and 6 positive burst are difficult to see using short distance electrode recordings. As you can see here, when using P8-202 as a derivation, using long distance recording, as you can see in this frame, going from P8 to A1, the activity can be better visualized. The burst is made of spikes of variable size, lower amplitude elements are at the beginning and at the end of the burst, usually. This arrangement is not always present, and at times tall and short spikes are intermixed. Most bursts last less than 1 second, and all last less than 3 seconds. The amplitude of the tallest component, when measured from the temporal region to the ipsilateral ear, should be less than 75 microvolts. The frequency of the spikes within the burst is 14 Hz or 6 Hz. Faster frequency, that is those closer to 14, occur in older patients, whereas slower frequencies, that is those closest to 6 Hz, occur in younger patients. Nevertheless, bursts with both frequency intermix, or at times bursts that predominate one but is also mixed with the other frequency, are recorded. The field of distribution is better appreciated using nasopharyngeal electrodes. These fields demonstrate a negativity in that electrode. Scalp electrodes, on the other hand, show a positivity, usually in the posterior temporal region, that may has a significant anterior spread to involve the anterior temporal region as well as the frontal region. At times, the field not only extends forward but also extends towards the earlobe. This activity can be rather significant in its spread to the earlobe and almost have the same strength than the posterior temporal region. The bursts most of the time are asynchronous, but at times they are synchronous and at times unilateral. When bilateral, they tend to be symmetrical, or at times having alternating predominance. They disappear upon arousal. Their defining feature are their bursting quality, their short duration, the posterior temporal parietal positive field, and their frequency. So the answer to this question is C. Next question. Which of the following is not true regarding 14 and 6 Hz positive burst? A. Maximal during 12 to 15 years of age. B. Their source is the posterior temporal mesial cortex. C. Similar formations can be seen in patients with hepatic coma. D. The field has a positive area in the nasopharyngeal electrode. The origin of 14 and 6 positive bursts was reported in a paper written by McLachlan and Luba. Their conclusion was that their origin was localized to the region of the posterior temporal mesial cortex. And additional interesting findings in this pattern is that at times patients with Rey syndrome, hepatic failure, hypoxic ischemia encephalopathy, and head trauma have an increased frequency of 14 and 16 positive bursts than healthy patients. So the answer to this question is D. Next question. Please take a look at this frame and choose from below. The possibilities are A. Lambda wave, B. Spindle, C. Lambda wave of youth, D. 28 Hertz spike variation of 14 and 6 positive burst. The answer is D. Next question. 28 Hz spikes intermixed with 14 Hz positive burst indicate an increased chance for seizures. A true, B false. 28 Hz positive spikes occur intermixed with 14 and 6 Hz positive spikes or burst. 28 Hz spikes must be distinguished from epileptiform discharges. They occur during drowsiness or early sleep. They may occur simultaneous with eye movements when they occur during drowsiness. They are best seen by using contralateral ear reference montage. The waveform consists of tiny spikes within a burst of 14 and 16 Hz positive activity. The tiny spikes last equal to or less than 35 milliseconds, and their amplitude is less than 50 microvolts when referred to the ipsilateral ear. Their frequency is obviously 28 Hz, thus being an harmonic to 14 Hz, which seems to be the fundamental rhythm in the 14 and 6 Hz positive burst. They have the same field distribution as 14 and 6 positive burst, and most often are asynchronous, at times synchronous, and rarely unilateral. When they are bilateral, they are usually symmetrical or may show alternating asymmetry. They tend to disappear with arousal. Their defining features are their 28 Hz recurrence, their field, which is posterior temporal or inferior parietal, and positive, the intermixing of the spikes among 14 and 6 Hz positive burst, and the fact that they tend to last less than 3 seconds. 28 Hz spikes are not linked to epilepsy. This conclusion and their association with 14 and 6 per second positive spikes was nicely reported back in 1991. The conclusion of that paper was that this activity has little clinical relevance, but its recognition is important so as not to confuse them for epileptiform activity. So the answer to this question is B. This is the chart that I have presented to you several times. This is the chart exposing all the activity that occurs in the temporal lobe. Please take a few seconds to look at it and compare 14 and 6 Hz positive burst with all the other activity that also occurs in the temporal lobe. The arrow here points to the fact that these 28 Hz positive spikes and wave are considered within the context of 14 and 6 positive bursts. Next question. Please take a look at this epoch and choose the best answer from below. A. Wicked rhythm. B. Lambda waves. C. Generalized ictal discharges. D. Huge N potentials. The answer is D. Next question. Which of the following is not true regarding huge N waves? A. First large wave is surface negative at FP1. B. Best montage to visualize pre-negative spike is one using F3 to F4 derivation. C. Huge N wave cannot be detected with bipolar montage. D. More common in patients with epilepsy. Huge N wave is also linked to 14 and 6 positive burst. It must be distinguished from epileptiform discharges, especially from those usually associated with generalized seizures. They occur during drowsiness or early sleep. They may be associated with slow extraocular movements when they occur during drowsiness. Huge N wave are best seen using contralateral ear reference, but they may also be appreciated using transverse montage. A huge H wave is a complex discharge. A large biphasic wave is preceded by a brief small sharp activity. This fast activity is at times better appreciated using a transverse frontal derivation, as you can see in this frame and in this new frame. Here, the biphasic and the preceding sharp activity looks bigger as a function of larger separation between F3 and F4 than between FP1 and F3. N wave duration is 1/2 to 1.5 seconds. They usually occur single. The first deviation of the N wave is often unusually negative in the frontal area, maximally prefrontal. This negative discharge is often followed or usually followed by a positive field discharge. The activity is synchronous and symmetrical. I have introduced this frame to show you the generalized distribution with the frontal predominance. Here the arrow is pointing to the left frontal region and here to the right frontal region. I have also introduced in this epoch a green rectangle to call your attention to the huge N wave present, which I have augmented further in this frame to show you the resemblance between the N wave and the letter N. This wave disappears with arousal. The defining features of huge N wave is its size, the frontal predominance, their association with 14 and 6 positive wave, and that they are present only during drowsiness or early sleep. This is from the same article I showed you before, that was published in 1991. It emphasizes the relation between 14 and 6 positive waves and huge N-shaped potentials. It stresses the fact that they are not linked to epilepsy and that it is important to distinguish them from the type of spikes and wave that we see in patients with epilepsy. This chart again summarizes the most frequent activity arising from the frontal region. Please take a few seconds to look and compare huge N wave with all the others. If you have to stop the recording at this point to look at them, please do so. In this frame, I have introduced inside the green rectangle a burst of 14 Hertz positive spikes. I have done this to show you a comparison with all the similar activity also that can be placed within the context of 14 and 6 positive spike burst. Here I have show you another activity in the same group in which there is intermix of 14 and 6 Hertz spikes. Here one with 28 Hertz spike activity intermixed with 14 and 6 Hertz positive waves. And finally, I have introduced the huge N wave. It is important to stress that all of them have the same significance. In Fish book, it is stated that there is no proven relation with seizures. In Luther's they are referred to as benign variants. In Hughes' book, they are linked to behavioral issues, but in no case are they linked to epilepsy. So the answer to this question is D. Please take a look at this frame and choose from one of the options below. They are A. Lambda waves, B. Mu rhythm, C. Rhythmic temporal theta bursts of drowsiness, D. Theta waves. The answer is C. Next question. Which of the following is a characteristic feature of rhythmic temporal theta bursts of drowsiness? A. Occurs during deep sleep. B. Lasts less than a second. C. Amplitude is sustained. D. Frequency is sustained. Rhythmic mid-temporal theta discharges are also known as rhythmic theta bursts of drowsiness and as rhythmic mid-temporal discharges. They used to be called psychomotor variant. They are no longer called that way. The term that we would use most of the time will be rhythmic mid-temporal theta discharges. They usually present after 13 years of age, and they must be distinguished from rhythmic ictal spikes, mu rhythm, and focal slowing. They occur during drowsiness, but they may also occur when the individual is relaxed, but they never occur during deep sleep. Slow eye movements are often present. The correct montage to better appreciate this activity is the double banana. Waveforms are monomorphic for each burst, and slower rhythms may have intermixed fast activity, usually in the supraharmonic frequencies. Such an encounter produces a notch appearance in some of the bursts. The frequency is usually sustained throughout the burst. The supraharmonic activity usually lasts from 80 to 100 milliseconds, whereas the fundamental rhythm is usually about 150 to 200 milliseconds range. The rhythm is usually in the 5 to 7 hertz, as correspond to the slower activity, and bursts are usually longer than 1 second. The activity is distributed over the mid-temporal region, and the field is negative in that area. The activity is usually bilateral, but alternating, so is not synchronous. Tend to be symmetrical, but alternating asymmetries are often present. In this frame, I have introduced an epoch with multiple types of rhythmic temporal theta bursts of drowsiness. Notice the configuration of the waves in this frame, which greatly differ from the one highlighted in the green rectangle, from the one highlighted in the blue rectangle, and from the one highlighted in the aqua rectangle. So with the one in the yellow rectangle. The point of showing you all these rectangles is for you to notice that within a burst they tend to look very much alike, but the wave themselves may be quite different from each other. This activity disappears upon arousal. Its defining features are the mid-temporal location, their multiple shapes but constants within each frame or within each burst, their sustained frequency within each burst, and among bursts, and in some cases the typical notch appearance. So the answer to this question is D. Frequency is sustained. Next question. Please look at this frame and choose the best answer. A. Lambda wave. B. Mood rhythm. C. Rhythmic temporal theta burst of drowsiness. D. Zeigarnik rhythm. The answer is C. As we mentioned, rhythmic temporal theta bursts of drowsiness last longer than 1 second, and as shown in this case may be asymmetrical. Notice the sustained frequency and morphology in this example. Take a look in this general frame to compare the different activities that occurred in the temporal region. Take a few seconds to compare rhythmic temporal theta bursts of drowsiness with other activity which predominates in the same region. This is a picture of Prague. Please take a look at this frame and choose best answer. A. Lambda waves. B. Mood rhythm. C. Rhythmic temporal theta burst of drowsiness. D. Zeigarnik rhythm. The answer is D. Next question. Which of the following is not true regarding midline theta rhythm? A. May be asymmetrical. B. Focus is midline. C. More common in children. D. Occurs during drowsiness or stage 1. Midline theta rhythm is also called Zeigarnik rhythm. It is more often encountered after 20 years of age, so we usually do not see it in the EEGs that we do in children. Zeigarnik rhythm must be distinguished from ictal activity. It is usually present during drowsiness or early sleep, so it may coincide with slow extraocular movements. Zeigarnik rhythm is best appreciated using a transverse bipolar montage, where it presents as a smooth sinusoidal or arciform spikes conglomerate. They may look like Mu activity, and as you can see in this frame, have a spiky appearance. The frequency tends to be sustained during each burst and is in the 5 to 7 Hz range. The distribution of the field is midline, usually very localized to the CC electrode region, and it is therefore synchronous and symmetrical. Alternating asymmetries are sometimes found, but they are relatively minor. They disappear with arousal, and their most defining feature is their location below ZC, the sustained frequency of the arciform discharges, and that it is only present during drowsiness. This rhythm was first described in 1961. At the time, it was called theta discharges in the midline, and it was linked to temporal lobe epilepsy. Further reports in 1986 by Westmoreland and Class regarding midline theta rhythm concluded that this was a non-specific pattern, and certainly it was not linked to epilepsy as it was originally reported. So, despite the fact that the prediction that they were associated with temporal lobe epilepsy was not true, the name stuck. So the answer to this question is C. This is a general frame I have shown you in the past. This one compiles the central occurring grapho elements. Please take a few minutes again to look at it and compare SIGA-NEC rhythm with all the others. Next question. Look at this epoch and select the best answer. If at any time you wish to stop the video and take a few seconds to think about it, do so. The possible answers are lambda waves, B, lid flutter, C, sleep spindle normal, D, sleep spindle abnormal. The answer is C. Next question. Which of the following is not true regarding spindles? A. Mature spindles are fusiform. B. Must be more than 1 second. C. Central location. D. Present in stage 3 sleep. Sleep spindles have also been called sigma waves, a term that is no longer used. They are present after 2 months of life and continue throughout life. They are the hallmark of a stage 2 sleep. In this frame, I have introduced a polysomnographic recording to show you how spindles look at the speed that they are usually recorded for polysomnography. That speed is certainly increased, therefore the spindles are contracted, looking very much like a slight darkening and of the background rhythm with a slight, very tiny little spikes. Spindles may be confused with epileptiform discharges. They are the hallmark of a stage 2 sleep, as we just previously mentioned, but they may also be found during a stage 3 sleep. Rarely they have been described during REM. They are not linked to any sort of artifacts. In a sleep spindle, a word are well appreciated using double banana montage and also using referential montage to ipsilateral ear. By definition, they must be half a second or longer. The shape of the individual waveform can be monophasic or biphasic. They occur in bursts that may have a rectangular envelope or may have a spindle-like envelope, which is the envelope that characterize and name these structures. These birds tend to begin and end with lesser amplitude than in the middle. So the lower amplitudes are at the beginning and at the end of the burst. With the usual polysomnographic speed, as I had shown you before, they just look like thickened lines or background activity. The frequency of the wave within the spindle ranges from 10 to 16 Hz. Luders mentioned a rate of 10 to 12 before 12 years of age. And in Hughes' book, they talk about 10 to 12 Hz spindles being seen after 5 years of age and up to the age of 19 years of age. The bottom line is that whether just by the frequency, spindles can be divided in two groups, those that are above 12 Hz and those that are below 12 Hz, usually in the 10 Hz, is always an open discussion. They feel maybe maximal at the central region, at times at the frontal region. They seem to have the same significance when they are central than when they are frontal. The spindles are usually synchronous after 2 years of age. Before that, they may be asynchronous. They are usually symmetrical, and at most they may have alternating asymmetries, but it's usually relatively minor. They do not have any reactivity. In the classical form, they are fusiform. They have a frequency of 10 to 16 Hz, are bilateral, synchronous, and symmetrical, and these are the defining features of spindles. So the answer to this question is B. Next question. Neurons in the nucleus reticularis thalami are the spindle pacemakers. A true, B false. Neurons in the nucleus reticularis thalami are the spindle pacemakers. So the answer to this question is A, true. Next question. Neurons in the cerebral cortex are the spindle makers. A, true, B, false. Neurons from the reticular nucleus of the thalamus make contact with neurons at other thalamic nuclei and with neurons in the rostral brainstem called thalamocortical relay neurons. That is, both neurons, those in the thalamus and those in the rostral brainstem, are called the same way. These thalamocortical relay neurons send axons that make contact back with the neurons in the reticular nucleus of the thalamus and also with cortical neurons. The connection with the thalamus is made with the same neurons that originally made contact with the thalamocortical relay neurons. Cortical neurons then contact the reticular nucleus thalamic cells and also the thalamocortical relay neurons as shown in this frame. So it starts with neurons in the reticular nucleus of the thalamus, which we said before were the base makers of the spindles, that rhythmically secreting GABA neurons in this structure produce an inhibition that hyperpolarizes the cells in the thalamocortical relay neurons. These neurons, when hyperpolarized to minus 85 millivolts, generate a calcium action potential which excites the GABA secreting neurons in the reticular nucleus of the thalamus and also the cortical neurons. The cortical neurons' excitatory postsynaptic potentials, if rhythmical and massive, generate spindles. So the answer to this question is A. Next question. A 4-month-old with no spindle should make you consider the possibility of A. Lysencephaly, B. Hypothyroidism, C. Brain tumor, D. Premature birth. Dreyfus and Kersey consider that complete absence of spindles at age 3 to 8 months represent a severe abnormality. This dictum should be followed with great caution, since we only know that there are no spindles when an EEG reaches definite stage 3 sleep. If not, we are not certain whether there are no spindle because it actually never reaches stage 2. Having said this, one disease that should not be forgotten when no spindles are present is the possibility of hypothyroidism. So the answer to this question is B. Next question. The spindles seen in patients taking phenobarbital have the same characteristic than normal mature spindles. A true, B false. Extreme spindle, as those seen in patients taking phenobarbital, and normal spindles, that is normal sleep spindles, certainly have different characteristics. Extreme spindles are frontal, whereas normal sleep spindles are central and frontal. The frequency of extreme spindles has a wider range and is usually faster than that of normal spindles. Extreme spindles tend to be continuous, whereas normal sleep spindles are intermittent. They occur in intermittent bursts. Extreme spindles are usually more than 100 microvolts, whereas regular spindles tend to be less than 100 microvolts. Extreme spindle occur during sleep and awake, whereas normal spindle only occurs during sleep. Extreme spindles occur in patients taking phenobarbital and benzodiazepine. They have also been reported in patients with mental retardation and hyperthyroidism. Chlorhydrate at high doses produces excessive spindle. At regular doses used for sedation, some say it does, some say they do not. In fish, in the same book, in one area, it tells you that they do not produce it, and in another area, they tell you that even the amount used for regular sedation may produce them. This is an epoch demonstrating extreme spindle in a 6-year-old. Notice that they are mainly frontal and continuous. This epoch shows very fast spindle arising from the frontal region. Notice how prominent they are on both sides, but primarily arising from F2. The frequency of this spindle is in the 18 to 22 Hz. So the answer to this question is B. Again, take a look at the general chart. This one belongs to the activity primarily occurring in the central region. Compare spindles with other activities from the same area. And also, since a spindle also occurs in the frontal region, compare them with other activity occurring in that region. Next question. Please take a look at this frame and choose the best possible answer. A. Mitten pattern. B. Blink. C. Anterior lambda wave. D. Interictal pattern. Epileptiform. The answer is A. In this frame, I have added the picture of a mitten to show you the similarities. The thumb is the thin wave. The area of the fingers of the mitten is the large wave. Next question. Which of the following is not true regarding mitten patterns? A. Has been linked to psychosis. B. Has been linked to seizures. C. Occurs at the end of a spindle. D. Presents in stage 3 sleep. Some have given the size of the thumb in the mittens a clinical specific association. The largest thumb were related to thalamic tumors, the medium thumb to Parkinson, the thin thumbs to psychosis. In Misuli's book, they state that mitten patterns are clearly normal and that they are formed by the fusion of a spindle with a vertex wave. Hughes classified them as controversial. In Jasper's book, they say they are benign, and they are not mentioned in Lure's book. One thing is certain, that all agree that it is not an epileptic pattern. So the answer to this question is B. Next question. Which of the following is not true regarding mitten patterns? A. They occur during wakefulness. B. They are related to eye movements. C. The field is frontal. D. The slow activity is in the theta range. Mitten pattern must be distinguished from epileptiform discharges. They occur during sleep, mainly during stage 3, but also during stage 2. They are not linked to any artifacts. They are best appreciated when a referential to ipsilateral ear montage is used. They are also well seen when double banana montages are used. With double banana montage or with ipsilateral ear reference, mitten look like spindle followed by a slow wave. But not always this appearance is easily viewed. With certain type of mittens, the spindle doesn't look clearly formed, and the only thing that we see is just a few small waves leading to a large slow wave. The thumb in the mittens usually range from 80 to 160 milliseconds. That is the smaller wave close to the larger wave, or the smaller wave that precedes the larger wave, is in that range. The part of the finger in the mittens is in the delta range. The feel is primary frontal and negative. Mittens are usually synchronous and symmetrical, but at times alternating asymmetries may be noted. They are not associated with any type of artifacts, and their defining characteristic is to think of them as a spindle followed by a slow wave, whereas sometimes only a few waves of the spindle are seen. So the answer to this question is D. Please look at this epoch and choose A. Mitten pattern, B. Blinks, C. Wamp, D. Frontal spike and waves. The answer to this question is A. I like to take a few seconds to look at this epoch because of how intrinsic so many different patterns are seen. The one inside the magenta rectangle looks like a mitten because, as you can see, there is a spindle followed by slow wave. After that, as you can see, the spindle gets disrupted and only a few or a segment of the spindle is seen before each slow wave. Now, if you look at the aqua rectangle, you can see that it looks like a huge N wave. And if you look at the yellow rectangle, it looks like a spike and wave with the typical position of the spike at the beginning of the slow wave, as we often see in patients with generalized seizure disorder. The most striking graphoelement, nevertheless, is the mitten because it is the largest one and because it is frontal. Yet, huge N wave is a serious consideration, although the fact that it's not frontal will probably steer you away from making that diagnosis because, as you remember, huge N waves are usually frontal. The spike and wave complex in the green rectangle is more prominent in the central than in the frontal region, also leading you towards not being a frontal predominant seizure disorder. So, going back to the question as to which should you choose, the answer is A. Again, take a look at this chart. Here we are emphasizing the frontal predominant activities or graphoelements. Make sure that you compare mitten pattern with all the other ones that occurred in the same region. Next question. Look at this frame and try to choose the best answer. A. Rolandic spike, B. Wicked spike, C. K-complex, D. Vertex wave. The answer is C. Next question. Which of the following is not true regarding K-complexes? A. Spontaneous or provoke. B. From area 6 or area 9. C. The slow component must be less than 1 second. D. Present in stage 3 sleep. No one is quite sure why K is used to label this grapho element. One explanation is that the wave tends to be provoked by noise, as when someone knocks at the door of the EEG lab while the patient is having an EEG done and the patient is asleep. In polysomnographic studies, K-complex look like a vertex wave followed by a spindle. Intracortical studies have shown that the source of K-complexes is likely the lateral and mesial aspect of the frontal lobe. Frontal K-complex from Brodmann's area 9 and vertex K-complex from Brodmann area 6. K-complex must be distinguished from epileptiform discharges. They occur during sleep, during stage 2 and 3. K-complexes are associated with body movements. They are best seen using transverse bipolar montage or double banana with transverse chains. The complex wave, when analyzed from F4 to F8, consists of a sharp wave with a slow component, and superimposed to the slow component there is a fast activity, as you can see in this frame. The sharp wave lasts about 10 to 150 milliseconds. The slow component lasts from 250 to over 1 second. And the fast activity consists of a spindle, usually in the 12 to 14 Hz range. K-complexes are maximally expressed in the frontal region and less often in the central region at the level of the midline. Or at times they involve a much wider area involving not only CC but also PZ. They are synchronous, usually symmetrical, but as in all this type of grapho elements, alternating asymmetry may be encountered in normal K-complexes. K-complexes are triggered by sudden noises. Their defining features are their midline location, the presence of surface negative sharp wave followed by a slow wave with a superimposed spindle, and their appearance only during sleep. So the answer to this question is the slow component must be less than 1 second. Look at this, at the general table again. This one concerns with the activity that is primarily present in the central region. Again, check cake complex in relation to all the other similar location-wise activity. Thank you very much for your attention.